Good afternoon, everyone, and thank you for joining us today for this roundtable discussion about testis cancer research at Indiana University and the IU Melvin and Bryn Simon Comprehensive Cancer Center. My name is Shea Treadway. I'm a Senior Vice President at Principal Financial Group, and I live in Denver, Colorado with my wife, Sarah, and our 4 kids, a 9-year-old, a 7-year-old, and twin 5-year-olds. I am proud to be an IU Simon Comprehensive Cancer Center Development Board member and a testis cancer survivor. About 22 years ago, as a new college graduate and starting my first job out of college, I was diagnosed with testis cancer. As we did our research, my family knew that there was only one thing to do: fly from Atlanta, Georgia to Indy to go see Dr. Einhorn and his team. I actually remember how quickly Dr. Einhorn returned my mother's phone call and how quickly we had an appointment to head to Indy. Because of my experience with Dr. Einhorn and my involvement with the Cancer Center, I'm really proud to host this conversation today with 3 fantastic clinicians and researchers. I'd like them to introduce themselves now, and then we'll begin our conversation. So, Dr. Einhorn, we'll start with you. If you don't mind, please introduce yourself. Maybe tell everyone where you were trained, how long you've been at IU, and what specifically you do in relation to testis cancer research.
Sure. I think as long as I've been at IU, the answer is probably forever, but actually I joined the faculty back in 1973, so I have been here for a little bit more than 50 years. I am from Dayton, Ohio. I did undergraduate work at Indiana University, did a fellowship at MD Anderson, and I became interested in testicular cancer early on when I joined the faculty here, knowing that it was a disease that affects young patients. We don't do age discrimination, but young patients are more likely to respond favorably to chemotherapy back in those earlier days. And I had the good fortune to have come here at a time when we had a world-famous urologist, Dr. John Donahue. We became collaborators and very close friends, and that gave us an instant number of patients with metastatic testicular cancer because of that. And we were the first to do platinum combination chemotherapy, which started in 1974. And as they say, the rest is history. And that cure rate pre-1974 for metastatic testis cancer was 5%. And today in 2024, 80% of the patients with metastatic testis cancer that has spread beyond the testis will be cured and lead normal lifespan, the same as someone in the same age group that did not have cancer.
That's great. Thanks for sharing, Dr. Einhorn. And Dr. Adra, could you introduce yourself and let everyone know a little bit about your training, your tenure, and your specialties at IU?
Sure. Hi, everybody. I'm Nabil Adra. I'm a GU oncologist. I did my residency training, internal medicine here at IU, and then stayed on hematology oncology fellowship here at IU as well. I've been on faculty since 2017. So been at IU for a total of 13 years now. Been fortunate to work with a wonderful group of oncologists and urologists and collaborate with them. And during my training, I worked quite a bit with Dr. Einhorn. I was fortunate to do quite a bit of research in that area. And I had no chance but to stay here on faculty. It was too good of an opportunity, and just enjoy working with this outstanding group of physicians here.
That's great. Thank you. And Dr. Cary, our surgeon on the panel, do you mind introducing yourself as well?
Well, thanks for having me contribute to the surgical side of this conversation today. I'm Clint Cary. I came to Indiana to do my residency training in 2005. And that's where I was introduced to Dr. Richard Foster, who, as Dr. Einhorn mentioned, Dr. Donahue, he trained Dr. Foster and first got me interested in this surgery, the retroperitoneal lymph node dissection surgery for testicular cancer. And I left for a couple of years to do fellowship training at UCSF, and then was fortunate enough to be recruited back to help be a part of this program. And so currently I'm an associate professor in our Department of Urology here. I've been back on faculty now for about 11 years, and just honored to be a part of it today. Appreciate it.
That's great. Thank you. So as we start our questions, I'd like to start with a brief overview of testis cancer research at Indiana. So Dr. Einhorn, for those who might not be familiar, do you mind walking us through the history of your research and development and kind of what's now known as the gold standard for care for testis cancer?
Sure. Funny to use the term gold standard when we're using a different metal, platinum, for treatment of it, but nevertheless. No one invented platinum. It's a heavy metal like gold or silver. It's been around for a while. And a salt of platinum was synthesized, and the chemical structure, and of course, who isn't interested in chemical structures, right? But it's cystidimine dichloropplatinum. And that was the first time a heavy metal had ever been used as an anti-cancer agent. And it was done in a variety of common tumors like lung cancer, pancreatic cancer, breast cancer, colon cancer, with a modicum of success, but horrendous toxicity with kidney damage and severe nausea and vomiting. But in those early clinical trials that were done elsewhere, there were a small number of patients with testicular cancer where the drug was showing clear activity. And so we felt that this was a novel, unique drug compared to all other drugs in the oncological compendium. We felt we could figure out how to mitigate the toxicity, and we felt we could figure out how to combine it with other chemotherapy agents. So we did our first platinum combination chemotherapy study back in 1974 with a drug called vinblastine and another drug called bleomycin, abbreviated PVB. And to my utter amazement, even well beyond my youthful exuberance, this achieved a cure rate that literally was a 1 logarithmic increase from that 5% to 55% in curing young men who otherwise would have succumbed usually within the first year of diagnosis. And then we went on to do a bunch of phase 3 trials. We demonstrated we could reduce the vinblastine dosage without changing the cure rate. We also demonstrated in a very important study that we did not need 2 years of chemotherapy. We can stop at just 12 weeks. We then looked at another experimental drug, etoposide, and demonstrated that platinum plus etoposide as second-line chemotherapy, became the first time that an adult solid tumor had ever been cured with any type of second-line chemotherapy regimen. So we then looked at substituting etoposide for vinblastine, what's called B for bleomycin, E for etoposide platinum, showing that it had a slightly higher cure rate and much less toxicity. And then we later demonstrated that for the majority of patients getting 4 courses over 12 weeks, we can cure the majority of patients with just 3 courses of BEP over 9 weeks. So in 1 decade, we went from giving everyone 4 courses of platinum, severe toxicity, and 2 years of chemotherapy, to where most patients are now cured with 9 weeks of chemotherapy. Now, after that first 5 to 10 years, we became very much involved in mitigating the side effects from chemotherapy. The kidney damage was relatively easy to solve because platinum is a heavy metal like mercury. It just required hydrating patients with normal saline hydration and forcing a diuresis so that the drug would not accumulate in the kidneys. So patients can be treated as an outpatient with just several liters of IV fluids with platinum, with saline hydration. We next worked with Glaxo pharmaceutical companies. Studies were done in a ferret model that when people get nausea and vomiting, and just for a historical reference, the average patient would have 12 emetic episodes, vomit 12 times on day 1 of the first of 5 days of 4 courses of therapy. And it's not because of a weak stomach, but it's because of what's in the brain and the medulla oblongata and in the emetic center in the brain. So it's a central effect, not a peripheral effect on the abdomen. And so it's found that when platinum type of drugs are injected to a ferret, there is an increase in a chemical called 5-HT3. And so Glaxo, and we were involved in doing these studies, developed the first selective 5-HT3 receptor antagonist. And that revolutionized the successful treatment, just as the chemotherapy cured the patients, allowing patients to easily and safely be treated as an outpatient instead of an inpatient. And it's not that platinum causes no nausea and vomiting. Of course, it still does, especially nausea to some degree. But now the average number of vomits or emetic episodes on day 1 has gone from 12 episodes to 0 episodes. So those were major achievements in supportive care as far as that's concerned. We next looked at what to do with those patients who are not cured with BEP chemotherapy. And we were the first in the world to be looking at high-dose chemotherapy, giving 5 times the dosage of these drugs with what initially was bone marrow transplant, and has been gentrified to peripheral blood stem cell transplant. And when I have medical students in the clinic, I always tell them that it is remarkable that we can inject a heavy metal intravenously into a patient's veins and cure the majority of patients. But to this day, I think it's a miracle that those patients who were not cured with BEP, we cure about 2/3 of them with high-dose chemotherapy when they would otherwise not have been cured with standard dose chemotherapy. Now, in the last decade, one of my major areas of research is looking at late complications of chemotherapy, mainly with platinum-based chemotherapy. One of the aspects of this is that when one measures platinum in the serum or urine in cured patients 10, 15, 20 years later, it is still there. And that's probably why there is a slightly higher incidence in cured testis patients of second and other types of cancer, cardiovascular disease, high blood pressure, elevated cholesterol, and other type of aspects that we look at in our research profile, looking at late complications of the curative therapy, or what we refer to as a burden of the cured. So that's what's kept us busy over the 5 decades since I've joined the faculty here back in 1973. And I would add that there's not a place in the world that we could have done this at Indiana University. This is never a one-man or a one subspecialty area. We had Clint, Cary, and Tim Masterson here with us, who succeeded John Donahue and Richard Foster. We have arguably the world's best pathologist and Tom Albright. We provide a service that is unlike any other service provided. We give free consultations to patients around the world and help them and help their doctors manage their disease, whether they come here to Indiana University or not. So Shea, I want to thank you for organizing that. And with that, I'll give up the microphone, so to speak, to do the microphone drop here.
Yeah, no, that's great. It's just incredible hearing you tell that story, Dr. Einhorn. Just an awesome history lesson there. And I certainly remember Dr. Foster as well from my time at
sure
Indiana.
You do.
Yeah. So, Dr. Adra, maybe expand on that. Dr. Einhorn mentioned that not 100% of patients are cured with the standard regimen. Do you mind maybe just adding a little bit more of your thoughts around, are there current kind of emerging treatment options, clinical trials, things that are going on that you're working on?
Yeah, sure. So, as Dr. Einhorn mentioned, about 80% of patients with metastatic testis cancer or testis cancer that has spread to other parts in the body are cured with frontline chemotherapy. Unfortunately, there is 20% of patients who are not cured with frontline chemotherapy. And those patients, the cancer comes back. And, there are different approaches to treat those patients who have relapsed disease. Our strong preference here at Indiana University is to treat those patients with the regimen that Dr. Einhorn had mentioned, which is high-dose chemotherapy and stem cell transplant. Essentially, what you're doing here is you're giving almost 10 times the dose of the chemotherapy that you get in the frontline setting, and essentially wipe out all the cancer cells. When you do that, unfortunately, you also wipe out the normal stem cells that patients have in their body, and that's why you need to do a stem cell transplant to recover the patient's normal, essentially, blood cells in their body. With high-dose chemotherapy and stem cell transplant, we cure roughly around 60% of patients with relapsed disease or disease where the cancers come back. But again, unfortunately, there's about 40% of that subset of patients who have recurrence of their cancer. And for those patients, this is quite devastating because the treatment options are not great. So that's one major area of research that we've been working on. It's a personal passion of mine is drug development in testis cancer, specifically in patients who have refractory disease, cancer that is not cured with frontline therapy or BEP, and cancer that's not cured with high-dose chemotherapy and stem cell transplant. So we have a number of current and upcoming clinical trials looking at various agents in that setting. One of those clinical trials is essentially looking at those patients who get high-dose chemotherapy and stem cell transplant. And normally after those patients finish the high-dose chemotherapy, we just observe, we watch with surveillance and hope that the cancer doesn't come back. And we do have a clinical trial right now that's essentially looking at that same setting, but instead of just observing those patients after high-dose chemotherapy, we are randomizing patients to get oral etoposide, which is the chemotherapy drug etoposide, but instead of giving it in the vein, we give it as an oral pill, and it's given essentially once daily for a 3 months period of time. And the idea is we're trying to identify whether by giving oral etoposide for an additional 3 months, whether we can improve the duration of remission and whether we can improve on the cure rate with high-dose chemotherapy. So that's one area we've been very active on. Another big area is drug development in general, with newer drugs and newer non-chemotherapy drugs for testis cancer. As many of our listeners probably have heard from other cancers, there's a lot of drug development with targeted therapy, genetically directed therapy, and immunotherapies for other cancers like lung cancer, prostate cancer, and so on. We've done trials with immunotherapy in the sort of normal immunotherapy or traditional immunotherapy approach in testis cancer. And this was a trial that I actually did with Dr. Einhorn and colleagues when I was a fellow back in 2014, 2015. And unfortunately, that trial did not show any activity of the immunotherapy drugs. But we learned from all those clinical trials, and what we learned during that approach is that even though those immunotherapy drugs are not working, there are certain molecules that are overexpressed on testis cancer cells that we could potentially target. One of those molecules that we've sort of identified here over the past 5-10 years, et cetera, is a protein on the surface of testis cancer cells called Claudin-6. And this is essentially a tight junction protein that is overexpressed on pretty much all testis cancer cells. And we did a clinical trial a few years ago looking at an antibody targeting Claudin-6 in patients who have refractory disease. Again, those are patients who are not cured with frontline therapy or with high-dose chemotherapy. Unfortunately, that study did not show any responses. However, there are newer drugs in development targeting Claudin-6 that seem much more promising. And there's different approaches. One approach is with an immunotherapy drug. So essentially, this is an antibody that has two ends to it. Well, on one end, it attaches to our immune cells in our body, and on the other end, it attaches to Claudin-6 on the surface of testis cancer cell. So essentially, this molecule goes in, it forces your immune system to identify those cancer cells, those testis cancer cells, and fight them. This concept biologically makes a lot of sense. Those clinical trials are ongoing, and we hope to see good responses on those trials. Another interesting approach, which we are hoping to activate a clinical trial here in 2024, is looking at CAR T cells. So CAR T cells is essentially when you this is an approach that has been effective in other cancers such as lymphoma and others. And essentially what you're doing is you take out the patient's immune cells, you mix them and you teach them how to fight certain cancer cells, and then you infuse them back into patients and hope that the immune cells are now fighting the patient's own cancer cells. A similar concept is being developed in testis cancer with a CAR T cell approach, again, targeting the protein Claudin-6. There's an ongoing clinical trial that is looking at that approach, and we're hoping to activate this here soon and offer it to our patients as well. And a couple of other last points is there is another approach looking at targeted chemotherapy. So chemotherapy in the traditional sense is chemotherapy drugs that are infused in the body. They fight cancer cells, but they also unfortunately fight your normal cells. That's why with chemotherapy, you get the hair loss, you get the diarrhea, et cetera, because the chemo drugs are fighting your normal cells. But there is a newer approach with antibodies that are attached to chemotherapy. So those antibodies are infused into the vein, but the chemotherapy is not released in the system until the antibody attaches to cancer cells, and then the chemotherapy is internalized into the cancer cells. There is a drug in development for testis cancer looking at that exact same approach, and that is currently a clinical trial is being developed, and we also hope to activate this in 2024 and offer it to our patients. And then lastly is genetically sort of directed therapy. When we did some studies on testis cancer in general, we observed that there is a protein that's overexpressed in general on testis cancer called MET. And luckily enough, there's an oral drug called cabozantinib that is effective in targeting MET protein. This is a drug that's FDA approved in kidney cancer and very effective in kidney cancer. It has never been tested in testis cancer before. We are currently have a clinical trial underway here at IU looking at this drug, cabozantinib, in patients with testis cancer. We are quite optimistic with the results we're seeing so far. So this is in general sort of all of the clinical research that we're doing in patients who have refractory or relapse disease or are not cured with our current conventional chemotherapy approaches.
It's incredible, just the amount of work and different pathways that you all are taking. Really incredible story there. Dr. Cary, since we're talking about treatment outside of the standard chemotherapy regimens, do you mind maybe sharing a little bit around the role that surgery can play for these patients, or I guess any patient with advanced testicular cancer?
Sure. Just to go back, when you first asked Dr. Einhorn to explain all his research in this field, I thought you might have lengthened this conference for 5 hours or so. So he did a great job of summarizing it down.
Yeah.
Yeah, from a surgery standpoint, I mean, we've heard a lot about chemotherapy, but one of the great things about this is it's very multidisciplinary, and we still have weekly conferences where we talk about challenging cases with medical oncology, pathology, radiology, and ourselves to try to see what would be the best treatment approach. And surgery happens after chemotherapy is completed in a lot of cases, and then in some cases to try to avoid chemotherapy altogether. In a standard case, someone would get chemotherapy and have a residual mass left over, and then surgery would be indicated to remove that residual mass. And the biggest reason for that is in a non-seminoma type situation would be to remove teratoma. Despite all the advances we've seen with chemotherapy and how it's improved over the years, teratoma has been one of those things that we have not really figured out how to get rid of without having to operate. And so that's still a big part of the surgical aspect of taking care of testicular cancer patients. In addition to that, there are resistant tumors to something like Dr. Adra was mentioning. Not everybody is cured with initial chemotherapy, and some patients aren't cured with high-dose chemotherapy and still have either teratoma or resistant viable germ cell tumors. And so that's where surgery also can come into play. And that's what continues to make this specialty a very collaborative specialty where we all need each other to get to these excellent results. The other part of surgery is in the earlier stages of disease, when someone presents just with stage 2, where it's just inside the abdomen and it's isolated to just the abdomen. That's where surgery can also play a role and offer patients a high chance of cure with a well-done surgery, and can potentially avoid some of those late consequences that Dr. Einhorn mentioned that himself and Dr. Lois Travis here have done a lot of work in trying to figure out some of these long-term side effects. And so that would be the biggest kind of contributions to surgery. And we continue to try to, as Dr. Einhorn mentioned, Dr. Donahue early on, he was a huge pioneer in understanding how to do this operation safely. Obviously, it's operating around the aorta and vena cava, which is some of the largest blood vessels in our bodies. So how to do that safely. And kind of like with Dr. Einhorn, initially starting with a big, huge treatment regimen over 2 years and condensing that down, Dr. Donahue started with a very wide resection, and then over years of mapping studies and continued experience, reducing down the templates for surgery to how much or how little surgery is needed in certain situations. And so that's another aspect that we continue to work on, is to try how to mitigate some of the consequences of surgery and how to give people the amount of surgery they need without exposing them to too much risk.
Great, thank you. Just hearing you all speak of the different terminology and the different procedures and medicines, everything else, certainly bringing back memories for me and certainly refreshing my appreciation for the work that you all and your predecessors have done too. So thank you. Maybe just for any of you, if you don't mind, as a survivor, I know one of the things that we all worry about, on a regular basis is, will the cancer come back, right? And so just kind of curious, if you don't mind talking a little bit, any of you, about the research IU is doing around recurrence of testis cancer.
Well, testis cancer recurrence is much easier to detect than any other cancer recurrence, like lung, breast, pancreatic, colon, the more common cancers, because we have the quintessential tumor marker, serum HCG and AFP. So we are able to pick it up at a very early level. Now, the overwhelming majority of patients who recur, and remember, very few do recur once they achieve a complete remission, will recur within a 2-year period of time. Those patients who have a late recurrence, it can happen 5, 10, 15, 20 years later. Our latest recurrence ever was 42 years after previous treatment, is usually picked up in a patient who is perfectly healthy, has no physical findings, but has a serum tumor marker, AFP, alpha fetoprotein, that is elevated. This is another rare instance of where surgery is the primary treatment for metastatic disease, as chemotherapy for these slow-growing late recurrences are not curative where surgery is. So anyone who is human with any type of serious disease worries about recurrent disease. There are some online tools for looking at yoga, mindfulness, relaxation techniques, remembered wellness. But we also remind patients that they need to come in regularly, annually, even when they're beyond 5 years, for just a simple blood test to make sure that they don't have a recurrence that can be surgically cured before it causes any symptoms or physical findings.
Great. I know me personally, I've moved all over the country and had a series of primary care physicians over time. And I know when I'm doing my annual physical, the first thing I see every time is when we do the blood test, I need to do the tumor markers for
Exactly.
for my history there. So hopefully everybody is doing that. I know we're going to have time for questions, I think, from the audience. It looks like a bunch of people are submitting questions. So excited to get to that. And maybe I'll ask just one more of you all. I'd love all three of you to answer if you don't mind. And then we'll start getting to some of the participant questions. Clearly you all are making significant, kind of contributions to testis cancer, to research, to treatment. I think the results and your reputation speaks for itself. I'm just curious, what still concerns you? What are the things, or one or two things that really keeps you up at night regarding, your body of work here? And I would love to, maybe Dr. Einhorn, if you don't mind, first, and we'll go to Dr. Adra and Dr. Cary.
Well, I probably have a different question than you might anticipate, but what keeps me up at night, and this is not just testis cancer, is the fact that we're not always having availability of drugs that have been around for so many decades. If we run out of a drug for cancer X, where maybe people live 2 months longer because of the treatment, that's sad but not tragic. If we run out of platinum, as we have done, not at this institution, but other institutions, we're taking 25-year-old men who would have another expected 50 years of life who might not have that because of problems with obtaining drugs. This is not something we can solve at Indiana University, but this remains a worry.
Thank you. Dr. Adra. Yeah, Shea, when I thought about that question, I think the answer is pretty clear in my mind. So, what keeps me up at night is those patients who we still don't cure today. It's quite tragic, to be honest. We see many of those patients as being a referral center for testis cancer here. Many of those patients who come for clinical trials, those are patients who've went through initial chemotherapy and then high-dose chemotherapy, and they're still not cured, and they come for clinical trials, and unfortunately, many of those patients end up passing away from testis cancer. I think that's what keeps me up and makes me feel like we need improvement. Yes, we've achieved a lot, and Dr. Einhorn's research and with urology and Dr. Cary and Masterson, they've improved the surgical techniques, but I think we need to eliminate the perception that testis cancer is a solved problem completely. Yes, we cure the majority of patients, but there's still a small group of patients who are not cured. And I think it's our job to continue working with drug development to develop newer drugs and newer approaches to be able to cure not 80, not 90, but 100% of patients with testis cancer.
Dr. Cary?
Yeah, I would just add, one of the issues that has already been brought up is the late relapse of testis cancer. There is little understanding, exactly why that happens. Why does something lay dormant for years or even decades and then comes back? And also the biology of it is a little different. It's not as responsive to chemotherapy when it comes back in that late setting. And so all these great successes that we've seen with platinum-based chemotherapy don't seem to do as well with the late recurrences. And it would be nice to understand the biology and mechanisms behind that. And so more research would be nice to do in that area. And then I would say just continuing how do we continue to refine the surgical experience? And I think, the mentorship here is great, and the models that have been shown before us with Dr. Einhorn kind of never settling for what just was accomplished and always trying to continue to improve that. And same thing with Dr. Donahue and Dr. Foster before us, never being satisfied with what you've done and always trying to improve upon that. I think continuing that legacy is important and something that I don't know if it keeps me up at night, but definitely keeps me thinking.
Great. Thank you all for the answers there. All right, so we have a little bit of time here left. I thought we'd get to some of the audience questions. We've actually had dozens of submissions of questions, so I'll apologize at the beginning. We will not get to all of them, but I do think we'll commit to trying to reach back out directly to folks that submitted a question that we don't maybe get to, in this conversation, to make sure that we get things answered here. But let's go through some of the ones that are coming through now. So here's. So like Shea, I'm a 22-year testis cancer survivor, and my survivorship concerns involve the onset of cardiovascular disease. Are you aware of any men experiencing cardiovascular disease associated with chemotherapy treatment? And if so, does the chemo-affected heart need to be treated any differently than others experiencing non-chemo-affected cardiovascular disease?
Yeah, so I think I can address that. So we know that when someone is cured with platinum-based chemotherapy, they have what's called a hazard ratio of 1.8, which sounds worrisome. It seems, gee, it's almost twice the risk of someone the same age who never had platinum at all. But what that translates to is about a 2% higher risk compared to someone the same age who never had cancer and never had chemotherapy. So there are things you can do to mitigate that risk, and they're obvious things. Don't be a smoker. Don't be obese. Exercise regularly. Have your cholesterol checked. Have your blood pressure checked. We're not going to go back to an era where we don't give people platinum, obviously. Now, the cardiovascular disease, elevated cholesterol, elevated blood pressure are no different than people who have those same maladies, which are very common, who have never had chemotherapy at all. But we try to do well adult follow-ups when people are coming in beyond 2 years, beyond 5 years, and making sure that all these things are taken care of because they're very important as far as any type of patient. And that's not just for testis cancer. We all should eat a healthy diet, not be overweight, exercise regularly, have blood pressure checked, have cholesterol checked, and not be a smoker.
Great. Thank you. All right. See, next one. Is there any research regarding secondary cancers like prostate, bladder, urethra, et cetera, if you had testis and cisplatin treatment? Are there any longevity studies for survivors of testicular cancer?
Yes, I can take that. So there's data that patients who have testis cancer were treated with chemotherapy with above a certain limit of etoposide, and that's really the drug that has a dose-dependent cause of secondary cancers, mainly leukemia. Patients who've had high doses of etoposide can have a slightly higher risk of secondary leukemias later on in life. And that's something that's been identified, and that's something that we watch. So when we see those patients who were treated with high-dose chemotherapy and transplant, we usually, in addition to their annual AFP and ATG and tumor markers, we would check a CBC as well to look at their blood counts and so on. As far as solid tumors, we don't necessarily see a substantial increase in percentage of solid tumors in those patients, but those studies are ongoing. We have the Platinum study with Dr. Travis and Dr. Einhorn looking at long-term effects of chemotherapy and trying to understand those patients who are 20, 30 years out, are they at higher risk of developing solid tumors like prostate, bladder, et cetera. But as far as we can tell for now, we don't see an increased incidence of those solid tumors.
Thank you. Let's see here. Dr. Cary, this one might be good for you here. So any thoughts on lab or robotic approaches to the RPLND, the node dissection surgery, or thoughts on prostate cancer screening in young survivors on testosterone therapy?
Yeah, the laparoscopic robotic discussion has been ongoing for 20 years or more. There are certainly some places that are trying this. Most of the studies that have been published are smaller in nature. I would say, being a huge referral center here, we have been referred patients that have had those approaches. And we've seen some unusual patterns of recurrences. We published some on this because some of that information wasn't out there in the literature. So that brings us some concern about that. I do robotic surgeries for other cancers, but I have not done it for testicular cancer. I'm not saying that we have completely shut the door on that potentially in the future, but it does bring us pause. As Dr. Einhorn mentioned earlier, these are patients that largely, even like yourself, you have 20 years, 30 years, 40 years, 50 years in front of you. And we've seen patients from a simple surgical approach, sometimes their lifespan shortened significantly. And so if we're introducing new technology, we just want to be cautious that it's being done well and that we're not putting patients at harm's risk. It certainly is something that's curable, and you have so many years in front of you. So again, I think there's room for continued exploration in this. I think I don't know if we're ever going to do it or not, but we certainly have pause when we see outcomes like that get referred to us. As far as the prostate cancer screening, as Dr. Einhorn mentioned, living a healthy lifestyle and doing all the cancer screenings that all of us should be doing when we get to certain ages are important. Prostate cancer screening in and of itself has kind of come under some scrutiny over the years, and I think it's kind of settled on having an informed conversation with your doctor about whether you want to be screened. But then even after you get diagnosed with it, there's some debate in the literature about testosterone supplementation or even testosterone causing prostate cancer. And there's actually been a fair amount of very well, or I'd say in good journals showing that isn't really the case. So I don't think testosterone supplementation, which a fair number of testis cancer survivors are taking, causes prostate cancer. It can cause a bump in your PSA, but it's not going to cause a prostate cancer. So I wouldn't be overly concerned about that.
Okay, thank you. Thanks for sharing. All right, let's see. Here's another one. My middle son was successfully treated by Dr. Einhorn 26 years ago when he was 19 years old. My question is, what is the probability of a testis cancer diagnosis regarding his brothers who are now aged 48 and 41?
Sure. So testis cancer, as most of the participants in the audience all over wherever you're in front of your screen are aware that it's a rare disease. And in the United States, about 1 out of 400 men will get testis cancer sometime in their lifetime, usually in their young lifetime. It's a disease of young men. So if you want to look at the bad news, a brother or a father or a son, there is a familial incidence which gives you a higher risk. What is a higher risk? It's 1 out of 300 instead of 1 out of 400. So I think brothers or sons should be aware of the fact that there is a family history of testis cancer and not to ignore if you feel a lump or a bump in the testis or pain in the testis that is persistent. But it's 1 out of 300.
Great. And speaking of self-exam, so here's a question. What's the best guidance for self-exam and early detection for those of us who work with young men so we can share something with them?
I guess I can take that one. I would say, a self-exam is something that is encouraged. I think there's actually the Testis Cancer Awareness Foundation who helped, I think, promote this conference a little bit. Has some good instructions on how to do that on their website, which I think is very useful. I would say, it's as easy as if you feel something abnormal, then you should let someone know. There are normal structures around the testicle that a lot of potential patients will feel, and it doesn't necessarily mean that there's cancer there. So not everybody that comes to be evaluated for something that they felt is going to have a testicular cancer. But I certainly think if you feel something that either wasn't there before or is painful or you think is abnormal, then you should have it evaluated by a physician and potentially have an ultrasound. And I think that's valuable information for any young man.
Thank you, Dr. Cary. All right, let's see. Here's another one. What are the best treatment options for late recurrence of seminoma, such as after the 5-year mark after surveillance?
Clint, I think that's probably best for you also.
So as I mentioned earlier, late relapses aren't as responsive to chemotherapy. Now, that is a little dependent on if they were ever treated with chemotherapy in their initial diagnostic period. What we've found is that they are somewhat more responsive to chemotherapy if they've never been exposed to platinum chemotherapy before. That being said, if they were initially treated with chemotherapy for metastatic seminoma and were cured for a period of time and then had a late relapse, then we get into this issue where chemotherapy is not as helpful anymore and it becomes more of a surgical issue. And depending on the situation, that can be a relatively straightforward surgery, or it could be a very complicated surgery. But it's largely surgical in nature. Those surgeries the success of those surgeries are very dependent on how it's done, meaning can we get everything removed? And sometimes that requires complex operations where we have to remove some of the major blood vessels like aorta or vena cava to achieve a complete resection. So it can be complicated. It isn't always, but it's largely a surgical issue, and it has to be done well, and hopefully by folks, not just us, but other centers that do this with some volume.
Great, thank you. Let's see here. What else do we have coming in? All right. So this is probably our last one here. So because IU has been such a powerhouse in this cancer research for so long, I'm sure it will come as no surprise to anyone listening that you all have received many grants from the National Cancer Institute and other funders. Those grants, of course, don't cover 100% of your work. Can you talk a little bit around how philanthropy has aided your research here?
Well, I can start off with that. Certainly, when we did these initial studies in 1974, we did it on a shoestring budget. We had no grants, we had no support, we had no industry support, but those were simpler times, and research is much more complex and much more expensive than it's ever been before. The major granting agencies, such as the National Cancer Institute, not inappropriately, tend to look at testis cancer as a rare disease where the majority of men are cured and want to focus their money on lung cancer, which is by far the #1 cause of cancer death, pancreatic cancer, breast cancer, colorectal cancer. So it's not easy to get grant support. We have grant support from the NCI now for 10 years running, looking at late complications of therapy. That's not looking at new treatments. And what Nabil Adra is talking about is developing these novel new treatments that can still look at these patients that today are incurable, but might later be curable. Without philanthropy, we would not be able to do these studies. And I'll just give you one example of what Nabil Adra was talking about. For patients who have to go through high-dose chemotherapy because they were not cured with their initial chemotherapy, that's a lot of toxicity to endure, and I won't go into all the side effects with that right now. But even after going through high-dose chemotherapy, as Nabil mentioned, about 40% will recur. So there is evidence that a simple pill, daily oral etoposide, might be able to lower the probability of recurrence. How do we find that? Not by guessing, not by a blind hypothesis, but by doing a well-controlled randomized study where half the patients get no further treatment and the other half get an oral etoposide pill for 3 months, as Dr. Adra mentioned. So how do we fund that study? Well, we're not going to fund it through the NCI. They're not going to fund something like that. We're not going to fund it through industry because it's a generic drug. So we had a very generous patient who had been through high-dose chemotherapy who gave us a personal philanthropic gift of $100,000. We would not be able to do this study, which may indeed improving the cure rate of these patients without that type of philanthropy. And that's just one of many examples, and Nabil can give many others. If you want to chime in, Nabil, what you've done with cabozantinib and our other transplant patient who was so generous.
Yeah, Shea, I mean, I think philanthropy is huge in this disease. Again, it's a rare disease. Part of the other issue with testis cancer as well is IU is a center of excellence, and we wish we could treat all the patients who have testis cancer, but of course, many of those patients have to travel across the country to come here to get treatment here and other places of testis cancer excellence. And traveling to IU or Indianapolis puts a lot of financial burden on patients who are already dealing with cancer and can be very difficult for them to endure all that. So one of the other creative ways that we have used philanthropy is to support patients in their travels and to be able to accommodate them with travels and hotel stays in Indianapolis to be able to receive those novel treatments that we're offering on clinical trials. And that wouldn't be possible without philanthropy. And this was actually made possible by a philanthropic fund by a patient of ours who was previously on a clinical trial here at Indiana University as well. The other aspect of it too is we had philanthropy support, which have helped us look at new biomarkers in testis cancer. So we didn't talk about this a lot, but there's a couple of blood tests. One is called microRNA 371. The other is called circulating tumor DNA. And those are blood tests that can detect microscopic amounts of testis cancer in the blood potentially. And with the help of philanthropy, we were able to fund a large part of this novel research that we've been doing, us with collaboration with others as well. And this simply would not be possible if we did not have those philanthropic funds.
That's great. Thank you for sharing those examples. I know with my involvement with the development board at the Cancer Center, I've been able to hear just a ton of great stories around people that have made sizable donations to fund specific things, but also just folks that are giving every little dollar that they can along the way. I know it all adds up and helps support all the work, and I know me personally will remain committed to helping raise money and donating myself as well. So thank you. I know it's every dollar that comes into you all is a dollar that's well taken advantage of and gone to goes to really good work. So, hey, I think that's all the time we have here today. I want to thank everybody for watching. Thank everybody for your time today. Thanks for submitting all the great questions that helped create a really good dialogue with Dr. Einhorn, Dr. Adra, and Dr. Cary. Hey, thank you three for participating in this conversation. I know it was impactful to many. I think I know I can say speak for everyone impacted by testis cancer when I say that, hey, I'm so grateful for your work, for your passion, for your dedication. And I can't wait to see what happens, on the horizon. I know there's just so much exciting, good work that's continuing to happen that'll continue to change outcomes. So thank you there. My life has been greatly impacted by your work and by the dedication of so many at IU. And so thank you for that. On behalf of my family, I'd like to close with a simple thank you. So thank you all. And then lastly, just for those of you who registered, please watch for an email. You'll get a link that'll have a link to this recording as well. So you can rewatch or go back through any questions. Thank you very much. Appreciate your time. Thank you.
Thank you.
Thank you very much.